Bismillahirrahmanirrahim. On to the third part. So it is abruptio placenta. The risk factors. Risk factors are trauma, smoking, cocaine use, and hypertension for abruptio placenta. Clinical features are constant abdominal pain, unlike pain associated with the preterm labor, which is intermittent as uterus relaxes and softens between contraction. Back pain may also be present, bleeding, fetal decelerations, and loss of variability. Physical examination will show a tender uterus, distended uterus with a fundal height larger than expected, unusually low amplitude but frequent contractions of a firm uterus. This is due to uterotonic effect of the blood concealed behind the placenta. Due to physiologic hypervolemia, the patient may appear hemodynamically stable until up to 20% of the blood volume has been lost. Fetal heart rate tracing will show minimal variability, decelerations, and uterine tachysystole, that is more than 5 contractions in 10-minute period. Complications can be maternal, like disseminated intravascular coagulation due to the tissue factor released by residual bleeding and hypovolemic shock. Fetal complications due to abruptio placenta can be hypoxia and preterm delivery. Management is IV fluids, which is the first step. Then place the patient in the left lateral decubitus position to displace the uterus of the aortocaval vessels and increase the cardiac output. Differentials for abruptio placenta are uterine rupture. Positive history of uterine surgery or myomectomy is important for that diagnosis. Loss of fetal station, diminishing contractions, and palpable fetal parts. These four things must be present for uterine rupture, and also vasa previa, that is painless vaginal bleeding and fetal heart rate abnormalities after amniotomy. Placental abruption. The risk factors are maternal hypertension or preeclampsia, eclampsia, abdominal trauma, prior placental abruption, cocaine and tobacco use. Clinical presentation will be sudden onset vaginal bleeding in 80% of the cases, abdominal or back pain, high frequency, low intensity contractions, hypertonic tender uterus. The diagnosis is primarily by clinical presentation. Ultrasound, not required for diagnosis to rule out placenta previa, may show retroplacental hematoma. So these are decelerations which are evident on the CTG in placental abruption, and uterine contractions can be seen like this. So for the CTG pattern, it was that there will be minimal variability. Decelerations will be there with uterine tachysystole. As you can see that the systole, that there is tachysystole, more than 5 contractions in 10 minutes are present in this uterine contraction graph, and we have multiple decelerations in the CTG. Decelerations are never normal. Decelerations must not be present. Then vasa previa. Vasa previa definition: fetal vessels overlying the cervix. Risk factors are placenta previa, multiple gestations, in vitro fertilization, and succentuate placental lobe. The clinical presentation are painless vaginal bleeding with a rupture of membranes or contractions, fetal heart rate abnormalities, for example, bradycardia and sinusoidal pattern, fetal exsanguination and demise. It is very dangerous for the fetus, and in most cases it is fatal. Management is emergency cesarean delivery. Management: vasa previa is diagnosed on fetal anatomy ultrasound at 18 to 20th weeks. It is managed with C-section at 35 to 34 to 35 weeks gestation, that is prior to spontaneous labor. Preeclampsia. It is defined as new onset hypertension at more than 20 weeks of gestation. The timing is very important in gynae. So, preeclampsia is new onset hypertension at more than 20 weeks of gestation. If it is less than 20 weeks of gestation, then this is chronic hypertension. Proteinuria will be present. The presence of proteinuria differentiates the preeclampsia from gestational hypertension, I guess. Okay, so there was a table in the part 1, you may see that if I'm confusing it a bit. So proteinuria more than 300 milligram per 24 hour, protein and creatinine ratio of more than 0.3, and dipstick with more than 1 plus protein. Risk factors are nulliparity, multiple gestation, maternal age less than 18, advanced maternal age, diabetes mellitus. It is the risk factor because its sequelae are individual risk factors for preeclampsia, for example, diabetic nephropathy, vascular disease, chronic kidney disease, and prior preeclampsia. All of these are the risk factors for development of preeclampsia. Patients at high risk of preeclampsia should get a 24-hour urine collection for total protein at the initial prenatal visit for the following reasons. To establish the baseline renal function, look for nephrotic range proteinuria so that the patients can be put on anticoagulation during the pregnancy and postpartum. Pathophysiology, abnormal placental development and function, chronic uteroplacental insufficiency, fetal growth restriction, and low birth weight. Preeclampsia can be divided as preeclampsia without severe functions, preeclampsia with severe features, that is severe hypertension defined as systolic blood pressure of more than 160 millimeters of mercury, diastolic pressure less more than 110 millimeters of mercury for more than 15 minutes. So this is the definition of preeclampsia. That is severe hypertension, systolic of more than 160 and diastolic of more than 110 for more than 15 minutes. Okay. Actually, it is the definition of severe hypertension or preeclampsia. Alright. Preeclampsia contains severe hypertension with platelet count of less than 100,000, transaminitis. Transaminitis, I guess it is the elevation of transaminases like liver enzymes. I think so. Then we have creatinine more than 1.1 milligram per deciliter, headache, and visual changes. Generalized hyperreflexia is also commonly seen in preeclampsia patients. A sustained ankle clonus may be present. Maternal complications, abruption placenta, DIC and eclampsia, hepatic rupture, pulmonary edema, generalized atrial vasospasm, increased systemic vascular resistance, and increased cardiac output, and pulmonary edema will result because of that. Decreased renal function and decreased serum albumin and increased capillary permeability can also lead to pulmonary edema. Management includes supplemental oxygen, fluid restriction, and diuresis in severe cases. Antihypertensive drugs to administer are IV hydralazine vasodilator, IV labetalol contraindicated in bradycardia. Oral nifedipine cannot give in cases of ongoing emesis. Methyl-dopa is indicated in chronic hypertension due to slow onset, not in acute cases. Differentials include gestational hypertension, no proteinuria or severe features, eclampsia, seizures are present, intrahepatic cholestasis, pruritus is present, and elevated bilirubin. So these are the differentials, but for making it a diagnosis of gestational hypertension, there must be proteinuria or severe features. There must be no proteinuria or severe features which are seen with eclampsia. To make it a diagnosis of eclampsia, there must be presence of seizures. Intrahepatic cholestasis, pruritus is present, and elevated bilirubin will be seen. Preeclampsia, a table. Risk factors are nulliparity, obesity, pre-existing medical conditions like SLE and chronic hypertension, multiple gestation, advanced maternal age or age less than 18 years. Definition: new onset hypertension, systolic blood pressure of more than 140 and diastolic blood pressure of more than 90 millimeters of mercury at more than 20 weeks, and proteinuria or signs and symptoms of other end organ damage. Severe features are severe range hypertension, systolic blood pressure of more than 160 or diastolic blood pressure of more than 110, platelet less than 100,000 per millimeter cube, creatinine of more than 1.1 milligram per deciliter or 2 times the normal, elevated transaminases 2 times the upper limit of normal, pulmonary edema, visual or cerebral symptoms, for example headache. Management is less than 37 weeks, no severe features. Do the expectant management. If more than 37 weeks or more than 34 weeks with severe features, do the delivery. Severe range blood pressure, IV labetalol, IV hydralazine, and per oral nifedipine. Seizure prophylaxis, give magnesium sulfate. Preeclampsia prevention. Definition: new onset hypertension and proteinuria over end organ damage more than 20 weeks of gestation. Isn't it the same table? With the risk factors in management? No, the risk factors are listed here. So prior preeclampsia is a risk factor, like all the gynae conditions. The previous history of that particular disease is the risk factor for that disease to occur. Chronic kidney disease, chronic hypertension, diabetes mellitus, multiple gestation, and autoimmune disease. Moderate risk is with obesity, advanced maternal age, and nulliparity. And prevention is low dose aspirin at 12 weeks of gestation. Stroke due to preeclampsia mechanisms, activation of coagulation system, platelet aggregation, and vascular microthrombi formation that leads to cerebral vessel occlusion and ischemic stroke. Dysregulated cerebral blood flow leads to inappropriate cerebral vasospasm, increased perfusion pressure that will lead to rupture of intracerebral vessels and hemorrhagic stroke. Okay, got it. Most patients with preeclampsia do not require CT scan, but those with focal neurological deficits require a CT scan of the head to evaluate the possible stroke and help guide the management. Seizure prevention in preeclampsia patient with myasthenia gravis. So, like in these patients, we have to give valproate. Magnesium sulfate is contraindicated in the patient with with a myasthenia gravis because it may trigger the myasthenic crisis because magnesium interferes with the calcium uptake in the cells. So that will worsen the myasthenic episodes. So in these patients, we don't give magnesium sulfate like all of the patients with preeclampsia. In these patients, valproic acid is given for seizure prophylaxis. Medications to avoid in myasthenia gravis are magnesium sulfate, fluoroquinolones and aminoglycosides, neuromuscular blocking agent, CNS depressants, muscle relaxants, calcium channel blockers, beta blockers, opioids, and statins. Then we have eclampsia. Severe preeclampsia with seizures is called as eclampsia. The clinical features are hypertension, proteinuria, severe headache, visual disturbances, right upper quadrant or epigastric pain, 3 to 4 minutes of tonic-clonic seizures, and usually they are self-limited. Management is to administer the magnesium sulfate, administer antihypertensive agent, and deliver the fetus. Seizures are preceded by severe headache, visual disturbance like blurry vision, photophobia, and loss of vision, epigastric and right upper quadrant pain. There are no focal neurologic defects. Post-ictal state will be present. Differentials are epilepsy. It occurs in the absence of provocation and they are followed rather than preceded by headaches. Then eclampsia, it is the latest table that was updated in June 2021. So it is not very latest, but okay, I have these notes. So eclampsia is preeclampsia with new onset seizures. The clinical features are hypertension, typically severe, that is systolic blood pressure more than 160 or diastolic blood pressure more than 110 millimeters of mercury. Seizures typically tonic-clonic with post-ictal phase. Severe headache, visual disturbance that is scotoma, hyperreflexia and proteinuria. Diagnosis is mainly clinical. Bilateral frontal lobe edema on CT scan and bilateral frontal lobe edema on CT scan or occipital lobe edema. So you have to look for bilateral frontal lobe edema for some reason. Okay, let us see that. Just give me a second. So this is what frontal lobe edema, bilateral frontal lobe edema looks like, and that is a characteristic thing of, what is that called? Eclampsia and occipital lobe edema. Let's see that as well. Occipital lobe edema. So that looks something like this, or like this. So these lobes can become edematous in the cases of eclampsia. Coming back to our discussion, so here we go. Management of eclampsia is with magnesium sulfate infusion, antihypertensive agent for severe hypertension, and delivery. With eclampsia, you have a risk of brain injury and an increased risk of stroke. You give magnesium sulfate to prevent the recurrence and deliver. Pathophysiology of pulmonary edema in preeclampsia. Pathophysiology of acute pulmonary edema in preeclampsia. The symptoms will be dyspnea, hypoxia, basilar crackles. Okay, so generalized arterial vasospasm, systemic hypertension, increased afterload against which the heart is pumping. So there will be high cardiac afterload, increased capillary pressure, pulmonary capillary pressure that will result in pulmonary edema. There will be low albumin, which results in pulmonary edema, and decreased renal function, which also culminates to the development of pulmonary edema and increased vascular permeability. Postpartum preeclampsia. Preeclampsia can present in postpartum patients up to 6 weeks after delivery. Presentation: severe headache in bilateral occipital or frontal regions. Most common presentation. This headache does not improve with the acetaminophen or NSAIDs. So antihypertensives in pregnancy. First line is beta blockers like labetalol, calcium channel blockers, nifedipine, hydralazine, and methyldopa. Second line is clonidine and thiazide diuretics. Contraindications are ACE inhibitors, angiotensin II receptor blocker, direct renin inhibitors, nitroprusside, mineralocorticoid receptor antagonist, that is spironolactone. Reactive non-stress test confirm that there is adequate fetal oxygenation and uteroplacental blood flow. So if it is reactive, like if there are accelerations and there is baseline variability, so it is a good test. Like it is a reactive test, and that is a good thing. A reactive non-stress test done in 20-minute interval, because in some cases when we are doing the CTG and when we are doing the NSTs, so there may be the duration of fetal sleep. So we carry it for at least 20 minutes to rule out the sleep period, I think. Okay, then we have baseline is there 110 to 160 plus, like that is a heart rate. Moderate variability of 6 to 25 per minute. The example is has been this example has between 120 to 140 variability. What does that even mean? More than 12, moderate variability of 6 to 25 minutes, good, right? And this example has between 120 to 140. I just couldn't understand this line. More than 2 acceleration in 20 minutes, and this has 2 in 10 minutes. Okay, so 4 is peak more than 15 minutes above the baseline, lasting for more than 15 seconds. And this is non-stress test. The definition is tracking the fetal heart rate for 20 to 40 minutes, and this is uterine contraction chart. So if it is reactive, it means that it should, when will we call it reactive? If there is a baseline of 10 to 160 minutes, moderate variability of 6 to 25 minutes, more than 2 accelerations in 20 minutes each, peaking more than 15 minutes above the baseline and lasting more than 15 seconds. The non-reactive is which does not meet this criteria for reactivity. Antepartum fetal surveillance. Firstly, we do the non-stress test. Description is external fetal heart rate monitoring of 20 to 40 minutes, done if mom can't feel fetal movement. Normal more than 10 movements per 2 hour. Normal result is reactive more than 2 accelerations, peaking more than 15 per minute and lasting more than 15 seconds, variability of 6 to 25 per minute. Abnormal results are non-reactive, less than 2 accelerations, and recurrent variable or late decelerations. Then the biophysical profile, I think the mnemonic for that was Batman. B-A-T-M, the Batman. Okay, so it is B-A-T-M. Where's the A? And okay, so Batman means breathing, amniotic fluid, tone, movement, and I don't know what is for A, and the non-stress test. The non-stress test plus ultrasound assessment of the following: amniotic fluid volume, fetal breathing movement, fetal tone. 2 points per category if normal, and 0 point if abnormal. Maximum is 10 out of 10 for the biophysical profile. So the normal is 8 or 10 points. Equivocal, 6 points are equivocal. Abnormal is 0, 2 or 4. We can't comment on if the child has 6 points. We have to repeat it in the scenarios. And oligohydramnios is also an abnormal finding. Then contraction stress test, external fetal heart rate monitoring during spontaneous or induced, for example, oxytocin nipple stimulation, uterine contractions, no late or recurrent variable decelerations, late decelerations with more than 50% of contraction. Doppler sonography of the umbilical artery, evaluation of the umbilical artery flow in the fetal intrauterine growth restriction only. High velocity diastolic flow in umbilical artery is normal. Decreased, absent or reversed end diastolic flow is abnormal. Fetal movements of more than 10 in 2 hours is normal and indicate low risk of fetal demise and normal acid-base status. Decreased fetal movement management. Do a non-stress test to account for fetal sleep cycle. Just give me a minute. Decreased fetal movement management. So we manage it like do a non-stress test to account for fetal sleep cycle. Non-stress test should continue for more than 40 minutes. 20 minutes for fetal sleep cycle and 20 minutes for non-stress testing. If it is non-reactive, do a biophysical profile or CST, that is contraction stress test. Biophysical profile has a total score of 10 and the mnemonic is Batman. So 0 by 10, 2 by 10 and 4 by 10 are abnormal PPP and we need urgent delivery in these cases. Less than 4, urgent delivery. If 6 by 10, it is equivocal, it does not tell us anything. You have to repeat in 24 hours. 5 to 7, repeat again. And 8 by 10 or 10 by 10 is normal. So more than 8 is good. Abnormal biophysical profile indicates fetal hypoxia due to placental dysfunction. Risk of placental dysfunction include hypertension, smoking, diabetes, or advanced maternal age. If a biophysical profile has been performed, a contraction stress test is not needed. Contraindication to CST are the same as contraindications to labor, for example, placenta previa and prior myomectomy. Non-stress test, reactive, baseline of 110 to 160 per minute. I think we have done that before, but okay. So moderate variability 6 to 25 per minute and more than 2 exhalations in 20 minutes. Ease peaking more than 15 per minute above baseline and lasting for more than 15 seconds. And when do we call non-reactive? When we call it non-reactive, if it does not meet the criteria for reactivity. The non-stress test uses the same technology as bedside fetal Doppler to determine the fetal heart rate, but then plots the fetal heart rate over time on a fetal heart rate monitoring strip. Okay, infertility. It is inability to conceive after 6 months of unprotected intercourse in women aged more than 35 years, or after 12 months in women less than 35 years. So, 35 years is the benchmark. After that, more than 6 months, and before that, more than 12 months of unprotected intercourse is required to give a diagnosis of infertility. Fibroids. Physical examination, irregular uterine contour, and enlarged uterus. Pressure effects will be urinary frequency or incomplete voiding. Constipation. These effects are caused by subserosal or pedunculated fibroids. Recurrent pregnancy loss due to submucosal, intramural, or intracavitary fibroids. They can lead to size date discrepancy. Obstetrical complications are miscarriage, malpresentation, abruption placentae, and preterm birth. For surgical management of fibroids, do hysterectomy if the patient has completed her family. If the patient still desires to conceive, do hysteroscopic myomectomy instead. So this is a table about fibroids. The clinical features are heavy prolonged menses, pressure symptoms of pelvic pain, constipation, and urinary frequency. Obstetric complications of primary impaired fertility, pregnancy loss, and preterm labor. Enlarged irregular uterus. Workup is ultrasound. Treatment is with asymptomatic. If it is asymptomatic, do observation, and if it is symptomatic, do combined hormonal contraception and surgery. Then types of fibroids, they are pedunculated, which are pendulous masses hanging out of the serosa. Then there can be subserosal. Actually, pedunculated and subserosal are the same types. If subserosal mass becomes pedunculated, it is the pedunculated fibroid. Then we have intramural, which is within the muscles or within the parenchyma of the uterus. Then we have submucosal, which is just below the mucus, and the intracavitary, which is inside the cavity. Degenerating uterine fibroids. Fibroids can grow rapidly during pregnancy due to increased estrogen and progesterone levels. However, because myometrial blood flow shifts towards the developing fetus and placenta during pregnancy, fibroids can outgrow their blood supply, leading to fibroid infarction and necrosis. Presentation: uterine contractions due to prostaglandin release, fundal tenderness, tender mass, leukocytosis due to inflammatory cytokine release. Diagnosis is on ultrasound. Management is conservative. Management with acute pain control is indomethacin for patients less than 32 weeks of gestation. Then we have this prolapsing uterine fibroid, this one. Okay. So this is an intracavitary fibroid that has prolapsed, and you may see the cervical dilation and all symptoms similar to labor. Okay, so labor-like pain with cervical dilation will be seen in prolapsing uterine fibroid. Contraction with hydatidiform mole, which is irregular bunch of grapes. Contrast this with hydatidiform mole, which is irregular bunch of grapes. This is rounded from. This is sarcoma botryoides, which has bunch of grapes coming from an infant. This is an embryonal rhabdomyosarcoma, as you can see over here. Okay, so labor-like pain with cervical dilation is classic symptom for uh, prolapsing uterine fibroid. So uterine sarcoma. Risk factors: pelvic radiation, which is the biggest risk factor. Then tamoxifen use and post-menopausal patients. Presentation is abnormal post-menopausal bleeding, pelvic pain or pressure, uterine mass. Diagnosis is with ultrasound with or without additional imaging, endometrial biopsy, and histopathology of surgical specimen. Treatment is with hysterectomy, with or without adjuvant chemotherapy and radiation therapy. Intrauterine synechiae, which are adhesions. So they're seen in the patients who undergo intrauterine surgery. Damage to endometrial basilis layer leads to inflamed and denuded endometrium, and that will cause the uterus to adhere to itself, and obliteration of the cavity will occur. Lack of endometrium results in light menses, secondary amenorrhea, infertility, negative progesterone withdrawal test. Patients present with a complaint of inability to conceive and monthly pelvic pain with little or no bleeding. Diagnosis is with hysteroscopy. Treatment is lysis of adhesions. Differentials include endometriosis, fixed tender uterus, not associated with amenorrhea. Recurrent fibroids are enlarged uterus and hairy menses. Intrauterine adhesions, risk factors include infection, septic abortion, and endometritis. Intrauterine surgery like curettage and myomectomy. The clinical features include abnormal uterine bleeding, amenorrhea, infertility, cyclic pelvic pain, recurrent pregnancy loss, and evaluation is done by the hysteroscopy. So, intrahepatic cholestasis of pregnancy. Increased estrogen and progesterone lead to hepatobiliary and decreased bile excretion. That will lead to increased total bile acids more than 10 micromole per liter. Okay. Risk factors are prior intrahepatic cholestasis of pregnancy, maternal age more than 35, and multiple gestations. Presentation is pruritus that is worst on palms and soles, no associated rash and right upper quadrant pain. Labs are increased aminotransferases. Alkaline phosphatases may be elevated but is not diagnostic because it is all produced by placenta. Complications are intrauterine fetal demise. Risk is particularly high when the serum bile acids more than 100 micromole per liter. Preterm delivery, meconium stain amniotic fluid, neonatal respiratory distress. Okay. Treatment is ursodeoxycholic acid. Intrahepatic cholestasis of pregnancy. The clinical features are developed in third trimester. There will be generalized pruritus. Pruritus is worse on hands and feet. No associated rash and right upper quadrant pain. Lab abnormalities include increase in total bile acids more than 10 micromole per liter, increased transaminases less than 2 times the normal, and with or without increased total and direct bilirubin. Obstetric risks are intrauterine fetal demise, preterm delivery, meconium stained amniotic fluid, neonatal respiratory distress syndrome. Management is delivery at 37 weeks of gestation, ursodeoxycholic acid, and antihistamines. Cholelithiasis in pregnancy. Symptomatic cholelithiasis in pregnancy pathophysiology, increased biliary cholesterol excretion, estrogen, and decreased gallbladder motility caused by progesterone. The clinical features are recurrent postprandial epigastric or right upper quadrant pain, right upper quadrant ultrasound with echogenic foci, stones, or sludge. Management is conservative, that is pain control. Cholecystectomy for complicated recurrent cases. Okay, then we have polymorphic eruption of pregnancy, like this thing. It is a dermatologic change. It is also called as pruritic urticarial papules and plaques of pregnancy. Causes pruritus and abdominal stria that spread centrifugally but spare the palms and soles. Treatment is topical corticosteroids. Then we have fetal growth restriction. It is an ultrasound estimated fetal weight less than 10th percentile for gestational age. It may be symmetric and asymmetric. Features are thin, loose skin, thin umbilical cord, wide anterior fontanelle, decreased subcutaneous fat, and meconium stained amniotic fluid in the cases of fetal growth restriction. This is a characteristic thing that you may see on the question. Some other can also be present. Placenta should undergo histopathology examination to evaluate for further infarction and or infection. Fetal growth restriction. So, symmetric fetal growth restriction occurs because of fetal problems. Asymmetric fetal growth restriction occurs because of maternal problems. So let's talk about symmetric first. Definition: ultrasound estimated. So basically, the definition is same for both of them. Ultrasound estimated fetal weight less than 10th percentile of the gestational age is called as fetal growth restriction. Symmetric onset is in first trimester. Etiology is chromosomal abnormalities and congenital infection. The clinical feature is global growth lag, like the fetus as a whole is not growing properly. Management is weekly biophysical profiles, serial umbilical artery Doppler sonography, and serial growth ultrasounds. In asymmetric fetal growth restriction that happens in second and third trimesters, there will be uteroplacental insufficiency and maternal malnutrition. The clinical features are head sparing, growth lag, like all blood goes to the brain, so it's bigger. So there will be head sparing growth lag, while in the case of symmetric, there is global growth lag. And the management is the same, that like weekly biophysical profiles and serial umbilical artery Doppler sonography and serial growth ultrasound. Then there's an other table about fetal growth restriction. Definition is weight less than 10th percentile for the gestational age. The risk factors are maternal hypertension, pre-gestational diabetes mellitus, genetic abnormalities, and congenital infections. Appearance is larger anterior fontanelle, thin umbilical cord, loose peeling skin, and minimal subcutaneous fat. Evaluation is with placental histopathology and consider karyotype, urine toxicology, serology. Neonatal complications are polycythemia, hypoglycemia, hypocalcemia, and poor thermoregulation. Hypertension and asymmetric growth restriction. Okay, so hypertension and asymmetric growth restriction. In the table, I think hypertension was not a cause. Uteroplacental insufficiency was present, and hypertension can cause this, or hypertension can be caused by this, maybe. Okay. Uh, Due to placental insufficiency in second and third trimester, abdomen size increases in second and third trimester, but in case of placental insufficiency, blood goes to the vital organs, that is brain, and lead to asymmetric or head sparing growth pattern. Okay, then we have septic pelvic thrombophlebitis. The risk factors are cesarean delivery, pelvic surgery, endometritis, pelvic inflammatory disease, pregnancy, and malignancy. Pathophysiology of septic pelvic thrombophlebitis is hypercoagulability, pelvic venous dilation, vascular trauma, and infection. Presentation is fever unresponsive to antibiotics, non-localizing signs and symptoms, negative infectious evaluation and diagnosis of exclusion. Treatment is anticoagulation and broad-spectrum antibiotics. Several factors predispose postpartum patients to thrombosis, hypercoagulable state of pregnancy, pelvic venous stasis and dilation, endothelial damage from infection and or trauma during delivery. What is anemia of pregnancy? Anemia of pregnancy is defined as hemoglobin of less than 11 gram per deciliter in first and third trimester, hemoglobin of less than 10.5 gram per deciliter in the second trimester. Differentials of thrombocytopenia decrease platelets in the pregnancy. So gestational thrombocytopenia means isolated, mild thrombocytopenia with a platelet count of 100,000 to 150,000 per millimeter cube. It is asymptomatic and it is a diagnosis of exclusion. Preeclampsia with severe HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. There will be moderate to severe thrombocytopenia with less than 100,000 per millimeter cube platelets. Hypertension with or without headache and scotomata, increased creatinine and increased AST and ALT, immune mediated thrombocytopenia ITP, isolated moderate to severe, that is less than 100,000 per millimeter cube platelets, asymptomatic or mucosal bleeding, bruising, and normal PT and APTT. Thrombotic thrombocytopenic purpura, which is caused because of mutation in the ADAMTS13 gene. It will cause severe thrombocytopenia, like less than 30,000 per millimeter cube. Neurological symptoms will, for example, confusion and seizures will be there. Fever, abdominal pain, and petechiae, and normal PT and APTT. Disseminated intravascular coagulation, moderate to severe, less than 100,000 per millimeter cube. Bleeding, for example, oozing and intravenous sites with or without thrombosis. PT and APTT, increased PT, increased APTT, and decreased fibrinogen will be there. Okay. Then we have gestational thrombocytopenia. It is a benign condition and a diagnosis of exclusion. So it is a benign condition with isolated mild thrombocytopenia, that's platelets 100,000 to 150,000 per millimeter cube. It is commonly diagnosed in third trimester. Management is reassurance and observation. What is HIT? That is heparin-induced thrombocytopenia. It is a paradoxical thing because HIT is a basically we give heparin as an anticoagulant, But heparin, because of an autoimmune reaction, causes increased thrombosis, and there will be consumptive thrombocytopenia, like platelets will be consumed so much that they will become deficient. So heparin induced thrombocytopenia. The clinical features are heparin exposure more than 5 days of any of the following. More than 5 days in any of the following. Drop in platelets count by more than 50%. Arterial or venous thrombosis. Necrotic skin lesion at heparin injection site. And anaphylactoid reaction after heparin. Diagnosis is serotonin release assay. Treatment is stop all heparin products and start non-heparin medications. Neonatal complications of diabetes during pregnancy are pathogenesis, maternal hyperglycemia, that is fetal hyperglycemia and hyperinsulinemia, increased fetal fat and glycogen stores, and increased fetal metabolic demands. Associated risks are prematurity, congenital anomalies, for example, caudal regression syndrome, macrosomia and associated complications, for example, brachial plexus injury and clavicle fracture, respiratory distress syndrome, increased insulin, decreased cortisol, and decreased surfactant, hypertrophic cardiomyopathy, lab findings, hypoglycemia, glucose less than 14 infant is hypoglycemia. Okay, then we have polycythemia, low iron, hypocalcemia and hypermagnesemia, and hyperbilirubinemia. So hypocalcemia is jitteriness seen in the infants. Okay, jitteriness is an involuntary movement that is particularly frequent in the newborns. It is hallmark in the tremor. The pathogenesis is poorly understood. Jitteriness is often accompanied by other signs of central nervous system excitation, such as hypermobility, hypertonicity, and ease of startle. Hypomagnesemia lead to PTA suppression, hypocalcemia. So hypomagnesemia causes PTA suppression and thus causing hypocalcemia. So first correct magnesium, then calcium. So that is the golden point. Normal physiological changes in pregnancy. So normal physiological changes are increased cardiac output that will result in increased stroke volume in early pregnancy and increased heart rate in late pregnancy. Decreased serum creatinine 0.4 to 0.8 mg per deciliter because increased renal perfusion. Leukocytosis because of inflammation. Increased urinary protein up to 300 mg per day due to increased renal basement membrane permeability. Platelets are normal or decreased. Some patients require gestational thrombocytopenia, that is less than 100,000 per millimeter cube, but more than 70,000 per millimeter cube, which does not require any further evaluation. Normal physiological changes during pregnancy. So renal or urinary system. Clinical findings are increased glomerular filtration rate and renal size, decreased blood urea nitrogen and serum creatinine until it is 0.8. Serum creatinine of 0.4 to 0.8. Okay. Mechanism is okay. It is like serum creatinine from 0.4 to 0.8 is physiologic. Beyond that is pathologic. Mechanism is increased cardiac output and renal blood flow due to progesterone with increased renal excretion. Urinary frequency and nocturia, increased urine output and sodium excretion. Mild hyponatremia, hormone reset threshold to increase ADH release from pituitary. Then heme, dilutional anemia, increased plasma volume and red blood cell mass. Prothrombotic state, hormone mediated decrease in total protein S antigen and activity, increase in fibrinogen and coagulation factors. Cardiovascular system, increased cardiac output and heart rate. Then we have blood volume, increased blood volume, decreased systemic vascular resistance. The pulmonary system include chronic respiratory alkalosis with metabolic compensation, increased PaO2 and decreased PaCO2. Progesterone directly stimulates the central respiratory centers to increase the tidal volume and minute ventilation. Then we have renal changes in pregnancy, cardiopulmonary adaptations. Then what is that? Coagulation cascade. I think we should do this. So the renal changes in pregnancy are physiological changes, increased renal blood flow, increased glomerular filtration rate, and increased renal basement membrane permeability. Lab findings will show decreased serum BUN, decreased serum CREAT, and increased renal protein excretion. Cardiopulmonary adaptation in pregnancy are maternal cardiopulmonary adaptation. Maternal adaptations are increased cardiac output, increased plasma volume, and decreased systemic vascular resistance. In the respiratory system, There will be increased tidal volume, decreased functional residual capacity because of elevation of diaphragm due to the mechanical effects of enlarging uterus. The clinical manifestations include peripheral edema, decreased blood pressure, increased heart rate, systolic ejection murmur, and dyspnea. So we'll start with the coagulation cascade in the next session. Until then, Allah Hafiz, fi amanillah, and take care.